A high-frequency linear array transducer with a lung exam type and a low-frequency curved array or phased array transducer with an abdominal setting is used for assessment of the pulmonary system. There are three specific areas of pulmonary ultrasound that are reviewed. These are 1. The utility of ultrasound to evaluate for the presence of a pneumothorax. 2. The use of ultrasound to detect and quantify the severity of lung parenchymal disease. And 3. The ability of ultrasound to detect and quantify pleural effusions. Each of these areas will be discussed. The utility of ultrasound to detect the presence of a pneumothorax is useful as this is a commonly known complication of various invasive procedures. To assess for a pneumothorax, one is evaluating for the presence of the lung sliding. This phenomenon relates to the sliding motion that occurs when the visceral and parietal pleura slide across each other during the respiratory cycle. The presence of lung sliding suggests appropriate lung expansion, and thus, absence of lung sliding suggests that the visceral and parietal pleura are not in contact with each. In the case of a pneumothorax, air between the visceral and parietal pleura creates the separation and absence of lung sliding. To evaluate for a pneumothorax, one will use the high-frequency linear transducer, as this will provide the highest degree of image quality of the lung pleura. The linear transducer is placed in the most anterior aspects of the patient in the supine position. Traditionally, working in a cephalad to caudad direction at the midclavicular line at the second or third rib spaces to the anterior axillary line at the base of the thoracic. The indicator should be at the 12 o'clock position throughout the scan. A view of the ribs is key to correctly identify the lung pleura that resides just below. Incorporation of M-mode imaging is useful to detect the presence of lung sliding as well, by evaluating for the presence of motion artifact below the pleura line. Finally, it is important to remember that the presence of lung sliding is reassuring to rule out a pneumothorax in the area of the ultrasound plane. However, the absence of lung sliding can be secondary to a multiple of factors and does not conclusively diagnose the presence of a pneumothorax. The second topic of pulmonary point-of-care ultrasound is the use of ultrasound for the detection and presence of lung parenchymal disease. Given the depth of penetration needed, a low-frequency curved or phased array transducer should be used. The transducer is placed in the second rib space at the midclavicular line with the indicator marker directed to the 12 o'clock position to evaluate the lung parenchyma from the anterior to posterior position. Moving in a caudad direction, the transducer should be placed approximately every third rib space along a diagonal trajectory from the midclavicular line to the mid-axillary line at the base of the thorax. Recent evidence has shown ultrasound to be exquisitely sensitive in detecting differentiation in aeration of lung tissue. This ability lies on a reverberation artifact that is generated when the ultrasound waves interact with lung parenchyma of different density, created from aerated and non-aerated segments of the lung parenchyma. This reverberation artifact generated produces a hyperechoic vertical line that extends from the lung pleural line through the parenchyma tissue, which should be greater than 8 centimeters. These vertical lines are termed B-lines and have been shown to linearly correlate to the severity in lung parenchyma aeration. The greater the number of B-lines depicts the greater areas of difference in tissue density in the lung parenchyma captured in the ultrasound plane. Thus, the process to evaluate the entirety of the lung involves placement of the ultrasound transducer in several places along the thoracic. Summation of the number of B-lines in each quadrant, along with the total number of B-lines, have demonstrated to be effective strategies at quantifying the magnitude of lung airspace disease. The third topic of pulmonary ultrasound is the utility of ultrasound to evaluate for pleural effusion. Ultrasound has been shown to effectively detect and quantify pleural effusion. There are two traditional patient positions for pleural effusion evaluation. 1. Sitting position, and 2. Supine position. It is important to note that the sitting position will allow the majority of lung tissue to be examined and allow the majority of the dependent area to be scanned in a single ultrasound plane. For either patient position, a low-frequency curved or phased array transducer is needed to allow for the appropriate depth of penetration. The transducer should be placed in the posterior axillary line with the indicator marker directed to the 12 o'clock position. A pleural effusion appears as a hypoechoic structure below the parietal pleural line. One is able to evaluate for complex or loculated pleural effusions by the appearance of hyperechoic structures within the hypoechoic pleural effusion space. One can qualify the amount of pleural effusion by measuring its diameter from the lung pleura base of diaphragm to the lung tissue. It is key to remember the impact of patient position on this assessment.